Thank you very much, Alex. Thank you, the rest of organizers. Thank you, sponsors. Thank you for making Strange Loop possible. Good morning, everyone. I'm here today to talk about Bench AI. Can you hear me well? Okay. So Bench AI is an organization that we started 2 years ago. So it's an earlier stage startup that focuses on bringing AI technologies, machine learning software to the most underserved communities in the world. Before I enter into more details about what we do, use cases, I wanted to give some context of why we exist. So first, 40% of the countries has fewer than 10 medical doctors per 10,000 people. To put more context here, European Union has as an average 50 doctors per 10,000 people, US 30, Nigeria has 4. Every day, more than 800 women die for reasons related to pregnancy that are fully preventable. All of those happen in low-income countries. HIV is still the leading cause of death for women in reproductive age worldwide, and AIDS is now the second most common cause of death among adolescents globally, and the first cause in Africa. So as most of you probably know, the incidence of preventable mortality is not a randomly distributed phenomenon. The most significant causal factor is poverty, and among them, people of color and children are overrepresented, and in this category, women and girls. However, despite of a lot of problems, has been a lot of improvements in the last decades. So these improvements are for two main reasons. First, because of the cheap, easy-to-use technologies that they have been implemented. For instance, vaccines, okay, one shot, done. Antibiotics, 1 week of treatment, very cheap, done. Contraceptives, or for instance, oral radiation therapy, just water, power, and you don't die of dehydration. The second block of improvements are related with behavioral changes. So for instance, boiling water, okay, this saves millions of lives. And this is what we are, what is our focus? This is what is our thing, behavioral changes. So we develop technology to promote behavioral changes toward better health outcomes. So this is our vision, nudging patients and provider behaviors towards better health outcomes. We focus on engagement, patients and providers. What does it mean? It means that vaccines and medication are useless if people don't take them. Vaccines and medication are useless if they are not in the shelf of the pharmacies or of the clinics everywhere in the world. So this is what is our focus. And before entering about what we are developing, I wanted to say a bit about where we are coming from, a bit of our story. So I say that our focus is engagement, patients, and providers. So indeed, our background is coming from the most engageable products in the world, video games. So since 2015, myself and part of the leadership of Benchi, we were working in Japan, and we built, I think, one of the best machine learning platforms for video games that predict individual player behavior, what they like, what they don't. We were thinking since then about engagement. So we were thinking about what are the data that is important, how much time do we need since a person starts playing a game to determine which kind of profile of player it is, which kind of data we need, which kind of format, etc. So, and this project started in 2015. It was in 2017 that people from Apple, they were the first to tell us, look, maybe we could apply this to healthcare. Okay? We were surprised. We were a very small team in Tokyo. And we continued with video games anyway, and in the middle of the pandemic, one person of that team moved to the Gates Foundation, and this is how everything started. So now that we are in the Japan section, I want to explain a bit the name. So Benchi is a profession that doesn't exist anymore. It's a Japanese word. It's a Japanese role that was in the cinemas when there were silent films, the only subtitles to understand the film, and most of the people in Japan were not able to read. Okay? So the benches were the ones who were explaining to the audience what was happening in the film. So this is what we want to think about ourselves. We want to explain what is hidden in the data. So Bench AI is an organization that is fully funded by the Gates Foundation, and our focus, our mission is understanding behavior with data, digital data, and intervening at the scale. Data and intervening. This is something that I'm going to be repeating all the time. Data, that's very important because we are working in low and middle income countries and there is no data. In terms of healthcare and in terms of many other areas, there is no data whatsoever. Okay? So this is something that this is very important. And intervening to be able to intervene to understand what is working and what is not. Our mission is, at the end, democratize adaptive interventions. And how we are going to solve this? With mobile phones. Okay, so we are going, well, as you know, mobile technology, mobile phones, cell phones are widely spread worldwide. 80% of penetration in Africa, 50% smartphone, 65% cell phone, although it's growing dramatically. And in low and middle income countries, the use of mobile health applications is widely spread. So much more than in high income countries. Why? Because it's much more needed. Okay? So at the end, I mean, this data generated by the users of those apps has a lot of information that so far is not analyzed, is not even organized, is just doesn't exist. Okay? So we can say in the status that it is. And also very important of cell phones is that they are able to reach everywhere. Okay? So if we want to scale interventions, it's the best way to do it. For that, we are building data-centric technologies. So what we are doing is first, organize tracking and organize the data that is relevant. Second, create a way that we can scale and we can democratize this kind of experimentation, intervention engines with all our partners in low and middle income countries in global health. Something just to mention is that global health is a field that is not techy at all, okay? So even conversations are very complicated. So part of our mission is leverage the quality of the technologies of applications in this area of the world and in this field. So we have developed an SDK to integrate and to be able to maximize the quality, but also if it is needed, either we redo the app if the backend is very bad, or we do apps from scratch with the data and the patient as a center, in the center. So our machine learning platform consists in two main parts, data and intervene, as I mentioned before. First, tracking the logs with the right label and the right format. And second, an intervention machine learning platform that focus on all the machine learning models that we have in production are to inform and to do better interventions. So what is inside is experimentation engine that includes clinical randomized controlled trials, A/B testing, advanced experimentation like reinforcement learning based, bandits, and also three types of machine learning models: recommendation, censoring, and forecasting. Censoring is time to an event to happen. Why? Because it's useful for the interventions. We are not doing predictions just for the sake of making predictions, that is very nice, but we focus on the action we want to take. Also, I wanted to talk about our vision of machine learning platforms. Sorry. So that for us, well, I mean, machine learning platform is to focus on the problem that we want to solve, okay? So, and the problem that we want to solve here is, again, nudging behavior, and for that, we want to include prediction of behavior and prediction of demand, okay? So that's the main core of our platform. And for that, I mean, the second most important step, first is the problem, second is the data, that is the element that we're going to use to solve that problem. So the data that we are going to track, and that is important for us, is every single click that the users perform and the interaction with the app. Okay, we want to see what they like, what they don't. Okay, which kind of video a midwife in Ethiopia is checking, and what is the one never checks or when drop out. We want to see, for instance, if a nurse is using it for include information, then maybe some pieces never do. And also the records that they include. Okay, if there are healthcare records, results of tests, or maybe just drugs that they buy in the pharmacy. All this information is what we store. And then all this information, we put it in a time series manner. Okay? The type of format that we use, always time series. We want to study behavioral changes, okay? So it's important to see how every person evolves in time. So we do personalize everything by person, personalized by content, by patient, if it's included in the app information. And then when it's predicted, for instance, that either a midwife is not going to pass a certification in an e-learning app, or either a person that has tuberculosis and has an app for adherence to treatment is going to stop taking the medication, so then we take an action to avoid this outcome or to promote an outcome to happen. Okay? So that is why we include predictions in our platform. So as I said, I mean, all what we do is time series data or time varying data at the end. So it is not that we have a problem of big data sets, but of course, I mean, it's high consuming because it can be long historical records. So what we do is what everyone does, just split, okay? Partition by month or depending on the type of ad that we are working with. So something very important that we found out is not that this is relevant for global health, I mean, unique for global health or unique for low and middle income countries, is that the data sets, I mean, people know that data is gold, we need to track the data, we need to save it, but what we have found most of the times is something that is fully useless, okay? So it's records that our team of data scientists that are hard data scientists put all their effort on the wall, but it's difficult to even distinguish between users, distinguish records, you don't know what is the truth, it's basically useless. So what we are doing with our SDK is first, and probably the most important role we have in this field, is organize those data. For that, this is also very important, we have created a unifying data labeling for behavioral model and demand optimization. Okay, so we have an opinionated system of name things and with the format that we want. So, and this is how is created the opinionated SDK. Okay, where again the role of the SDK is to track the logs and connect with the app and be able to send interventions and track again the interventions that already has the right format to feed the machine learning platform and visualize the impact. So this is the first step of our flow of how we work. So we have the JSON files, then through an SDK, we start transforming the logs into time series. Okay, so at the end, we have the metrics tables, we have per individual level, by content. So for instance, even if it's a drug, it's alive, okay? If suddenly the drug is not available anymore, the reaction of the user with the app is going to be obviously different. So also we create what we call traits. So there are different snapshots of information that is useful to create the target population for the experiments, okay? Something very important that we have in mind to create this platform is that there is no data scientist in this field. I never saw one, okay? So it must be a platform that is able to use some analyst or people that is involved in the organization. Of course, we are going to help them, okay, until they are able to scale, but it must be something that is easy to use. Also, something very important about that we are always repeating, okay, how we build our machine learning models, our engineering, is that and it has been mentioned yesterday as well in the two keynotes, indeed, is simplicity, okay? So we cannot have something that is even ourselves is difficult to understand, okay? So we want to have control of what we have, and simplicity is the best way of robustness. And also we don't want to solve problems that they never come. So, or maybe, they are not here yet. We have enough problems, okay? So, we love boring stack. It's something that we repeat a lot. And all that what we are building is to deliver AI to low and middle income countries. So I'm talking in a very abstract way. I want to go into more concrete examples. So for instance, it has been very difficult for us to be able to to be able to focus what is the priorities of the fields that we can have fastest impact. So for instance, one is primary care, another is women's health, epidemiology, and pharmacy. These are the 4 focus of our work. We help frontline health workers to triage with reinforcement learning or to send recommendations of scheduling if someone we think that needs a faster appointment, and also additional test recommendations. So we work a lot with midwives. Midwives are the last step in the chain of the healthcare system in most of the countries in the world. Women working with women, sometimes they are not even paid, just for tips that mothers give to them. So there are many organizations in the world that try to improve the situation, and many of them try to improve their skills. So there are online learning apps, okay, that try to improve this. We work with one of those, that is Maternity Foundation. So with them, what we do is to provide a personalized learning journey. So here, for instance, just some data of them. So these are the curves of learning of some midwives. In the y-axis is the probability of stopping using the app. In the x-axis is the different levels they have in the app. So we can see midwives that start with the app learning and then drop out very quickly. Others, like this one, in the middle, and those that there is a level that is very difficult for them. Okay, so we try to either send interventions or try to modify the level of difficulty. But this was before it was impossible to even realize. So another very important piece of our work is epidemiology. So we focus on tuberculosis in adherence to treatment, HIV adherence to treatment, with the medication, with PrEP, also prevention guidelines. So, and malaria is a very important focus of our work. So malaria can be prevented, diagnosed, and treated, but however, we have cases and deaths a lot, every year. So what we focus in this field is to personalize incentives, to frontline health workers or mainly pharmacists, to take malaria tests before treatment, because malaria is the most undertreated and overdiagnosed disease in the world. And the next step is help in the burden distribution and mainly incentives with the right setup, because if you have the burden at home but you don't put it correctly, it's useless. Also, the amount of variability of the SKUs of the drugs, of the medicaments that are in most of the drug stocks of pharmacy in the world is extremely low. Pharmacies are very important for our work. Pharmacies are core because pharmacies are the first point of care with the healthcare system of most of the people in the world. So you just go to the pharmacy. Some places only have the pharmacy. And sometimes if they go and they don't prescribe the right medicament at that moment, they don't come back. So they're extremely crucial, and the amount of drugs that they have is very limited. So they are very complex. This is a very complex problem. Okay, so for instance, in Africa, there is zero accountability of what is happening. Okay, which drugs are sold, what is the demand? Zero. Okay. So why is this? Is because, not only pharmacy, 90% of the retailing in Africa is done through middlemen, okay? So there are many layers, and everyone has different KPIs to maximize. So at the end, first, the products are extremely expensive, and second, the demand is completely diluted. So this is what is called bullwhip effect. So that what is the demand of the town, of the city, of the country, and what the manufacturer gets is fully, can be completely different. So because of many reasons, okay, so more and more they are developing, emerging these B2B e-commerce startups. So basically it's an e-commerce platform, but B2B. B2C will be very complicated in this area of the world. And a part of delivering much faster, cheaper, there will be data, okay? And there will be a connection with the pharmacist. And at the end, also, it could be with the patient. So so we work a lot with those B2B e-commerce platforms that they are emerging everywhere because this happens for in many fields. So we work definitely with pharmacists on this. We also work with an organization in Nigeria called Life Bank that use also an e-commerce app to distribute blood and oxygen among the clinics. So one doctor in a hospital just use the app and ask for more blood. So we help them with the prediction of the demand to assure that if there is going to be a lack of blood, they can start, for instance, a campaign beforehand. Or if they need to order beforehand, also do it. I mean, sending reminders. And also very important is what I was saying, like the data that we will be able to have about what is happening. Okay, so this is even useful to nudge behavior of pharma, of big pharma. Okay, because so far, I mean, it's not interesting for them. Okay, so just rely on those middlemen and whatever is fine. Okay, so first, I mean, what we are working already with one partner is creating, first helping them with the software and the data of the warehouse that they have. So be able to know, I mean, what is in stock and what is not. Connecting this with the app that the pharmacists have every time that they order, and also be able to have technology to scan prescriptions, to scan tests that they perform in the pharmacy, a lot of rapid tests, hypertension, all kind of devices that at the end we are able to even reach patients. This is a huge thing, okay, in terms of data. And I want to remind that low and middle income countries are 80% of the world. This is the partner that we have, and we are building this in Nigeria. Indeed, I was last week with them in Lagos. And yeah, I'm extremely excited because of the discoveries that we can find and how, I mean, it will be also a way to implement interventions, okay? So many organizations, USAID, Global Fund, wants to send interventions to tests of malaria, to governmental policy interventions. There will be a way to implement them, those incentives to pharmacies, and also a track of evaluate the impact of those. So before I go to just some experiments that we have performed, I wanted to talk a bit about other people that is also working in this field or has influenced our work. To be honest, there are not so many, okay? And I repeat, despite that we are talking about an area of the world that covers 80%. But I want to remark the work that Michael Kramer, Esther Duflo, and her husband Banerjee did, because it was indeed very important for us. So they won the Nobel Prize in Economics in 2019 for the use of randomized controlled trials in development economics. So basically, what they are doing is bringing experimentation before doing and deploy full interventions, okay? They are bringing evidence, okay? And this is how any intervention that has deployed in low and middle income countries, basically, it was done just with the intuition, okay? From the global north, which can be completely wrong, and it was in many cases. So the fact that we think something should work is not enough. It needs to work for the people who use them. It's a sentence that I like of Banerjee. And at the end, basically, those guys won the Nobel Prize just for bringing experimentation in this area of the world, okay? So again, so our platform focuses on intervention and experimentation. And I want to highlight how important is experimentation. So there's a sentence of John Dewey, what is the truth is what is accepted upon adequate evidence, and if they ask a description of evidence, we need to refer to matters of observation and experiment. Another team, I mean, we thought, I mean, we implement in production, deploy reinforcement learning, I think 2-3 weeks ago, and we thought they were the first, but indeed not, okay, in global health. So it is indeed the work of Milin that we discovered indeed recently, and we are already collaborating. His team, he's a professor in Harvard, and his team implemented in a call center in India. So a restless bandit, that is just a simplification, the simplest, one of the simplest ways of reinforcement learning algorithms, basically an agent that is able to learn on the fly and give different interventions to one another, and depending how you react, will be able to learn. So basically, I mean, that they did this implementation to help women, pregnant women in India, and they need to call them. I mean, they have a limited number of people that in the call center. They have a lot of pregnancy women in India, so they need to choose to whom to call to give them advice about tests, about follow-ups, etc. So with these algorithms, they are able to triage at the end how to select better the target population. And this is the partner that we have in Indonesia, where we implement at least first time in mobile health, in global health in low and middle income countries, this type of algorithms. So this is again a B2B e-commerce app, okay, so just to try to simplify the supply chain. And just, I mean, some data that we discovered in the first data that we analyzed. These are logs from the Stockout, okay, during the pandemic. And here we can see how, I mean, the type of drugs that were in Stockout precisely obviously correlates with the peak of COVID in central Jakarta. I think this is the data. So we can see that the main drug that was out of stock, it was respiratory, antiviral, painkillers, and vitamin supplements, okay? With proper prediction of demand, because indeed what's happening in other areas of the world before, that we will try to have, I mean, at least have those medicines in stock in the pharmacies. Also, something very interesting that we found with this app, okay, that we have observed also in others, is that the typical studies of engagement that we were doing with video games, okay? So this is a plot where in the y-axis is the connection time, in the x-axis is the in-app lifetime. So this means that the more you use the app, if you continue being more engaged and engaged. Normally this curve is an S, okay, so there is a point of saturation, there's a point that you don't use more the app, okay, or the game in the case, if it would be. So it was very interesting for us to discover that in this app, I mean, the more they use it, the more, the time increases, okay. So basically what it says is an amazing market fit. It's a product that people like to use and it's extremely useful. And this is the first experiment that we did with them. So it was a test, okay? So it was this summer. So basically we just chose some pharmacies for, we did some targeting based on purchase frequency regularity. And basically we said, okay, the goal was to increase the variety of the products that pharmacy has, okay? So we tried to motivate them, telling them, look, imagine, it's a personalized message, right? Okay, so if you are in a more rural area, so in central Jakarta, a pharmacy of your size, always that purchase this product that you purchase, also order this one that you never did, okay? And what was our surprise? That it was the first experiment, and it was clearly significant, okay? So purple means that it's significant, and also even within the interval, confidence interval. So what it means is that there is appetite for optimizing information, okay? So basically, in terms of implementation of algorithm is, many e-commerce do, Amazon, obviously, so this is something that in high-income countries, there are companies that they do, okay? But the revolutionary here is the field itself, okay, and the usage, okay? So we can use this type of recommendations that sometimes are useful, okay, in high-income countries to help them to be to have visibility about information that is very difficult for them to have. And this is the experiment that we started 2-3 weeks ago about, it's just a bandis in production that is not still, we don't see any effect yet, okay? So, but just to say the milestone that it was deployed. And one last, my last slide just focused on I wanted to talk a bit about our team, our culture. So just to mention that, I mean, this is the size of the team. So people from many parts of the world, I mean, Nigeria, Uganda, Lebanon, US, Iran, Pakistan, and well, this is very important for us. Obviously, okay, so we are a data science company, so to reduce the bias in data sets and algorithms, the most important thing, of course, are the team that is analyzing those data. So it's not an agent AI who is building the models. So if we are working with women in Africa, we need women from Africa that analyze those data and realize of the features that we need to include that maybe other populations wouldn't realize. And just to mention that, well, the leadership is majority women, except our CTO, and most of the women in tech, I mean, we have a bit more of women in tech, and almost half comes from low and middle income countries. So the type of roles that we have in our organization are definitely software engineers. We are building software. So data scientists, of course, product designers, and behavioral scientists. It's very important. At the beginning, we thought we didn't need behavioral scientists because the partners are going to know, I mean, which type of interventions to do. No. Okay, so we need to create a templates, type of interventions, and so on. And the behavioral scientists must come from the area of the world that we are working. We are based in beautiful Barcelona, so we have an office in Lagos, a small one in Nairobi, and we are recruiting. So we also publish some of our work when we have time. So we have a couple of publications in KDD last year and this, and also in EURIPS, and hopefully we'll have more accepted soon. And well, that's all. I mean, follow us in Twitter, and thank you very much for your attention.
So, sorry, can you hear me?
Yes.
All right, yeah. So very nice talk and inspiring work. I just had a question. You gave an example with the food voucher that, like, as an incentive to send to somebody to take their vaccination or something like that. So that seems an example for the actual, like, patient or, like, person, but, like, then the examples you gave for others were more on the healthcare provider side. So I'm just wondering from the actual, like, end user perspective, people you're trying to incentivize to take these things, given that, like, most of them have regular cell phones, so you don't really have a lot of data about them, like, what is your vision to reach them or get to them?
So basically, I mean, most of the frontline health workers, they have, okay? So this is the part of the population that they have a smartphone. The patient, in most cases, no, but they can receive SMS, okay? So with our platform, okay, we can reach either with push notification, of course, if they have apps, but also SMS is extremely important. And we work with apps that work with frontline health workers, but also with patients, okay? So in the case of mothers that they include the symptoms of babies and so on, they can receive also nudges in order that, or incentives, to get the vaccination of the babies, even if it's something that is physical, we can say. Welcome.
So you're talking about like trying to help doctors know to prescribe stuff and work to ensure patient compliance. But what about like risks of overprescription? I mean, I'm thinking like how antibiotics are sort of burning a bit of a global commons in terms of helping bacteria evolve towards being resistant. And like, I'm also aware that in a lot of places, people just think of antibiotics as sort of, well, health serum. And so might want it or be want it prescribed or be inclined to prescribe it, even in cases where it's not going to help. Does your app have anything to prevent, to have antibiotics be used only as they are helpful?
So we don't do prescriptions, we don't do diagnosis, okay? The type of recommendations we give are additional tests or things of the like, okay? We focus on the behavior, to help frontline health workers. We don't tell them prescribe malaria or pill or prescribe antibiotics or do nothing, okay? So this is something that we don't do. It's like, okay, try to find out more information if maybe we think that with the symptoms, maybe it can be a flu, okay, rather than malaria or things like this. What I mentioned about prescriptions is in the pharmacies, okay? So with the app, be able to take pictures of the prescription and have at least accountability of what is the bias of the hospitals in terms of what is claimed in the pharmacy. Because there are two cases, okay? First is that the patient goes to the pharmacy and asks for something, okay, I'm not going to live without the malaria pill, and the other is what the hospital is asking, also to understand the problem, basically.
Thank you.
Hi there. I was wondering, so the most important thing that we need to do when we're helping people is to listen to their needs. Is there a way that we could apply these kind of techniques to gather that information from folks, like kind of meet them where they are and gather their needs and feed that into a platform to inform like what development efforts we even need to make?
To be honest, I don't think so, okay? So we are not experts on that, okay? We always go with partners, and it's complicated, okay? So far, traditionally, has been surveys. Surveys are very slow, very slow. The cycle of intervention is very slow, and it's not working very well, to be honest, and also extremely expensive. So I don't think so.
Okay,
Yeah.
thank you.
There, sorry, I'm confused.
I'm curious, since Benji.ai's focus is on these behavioral nudges, are you able to detect differences in how effective these are compared to some of the other barriers in access to healthcare, like infrastructure and some of those other things? Because you mentioned you're working with like 80% of the world, so you'll see a lot of variability. Are you able to use this data to see these other obstacles more clearly?
Well, I mean, we don't work yet with 80% of the world, but
Sorry, yeah, that's the goal.
but I hope. But yeah, I mean, definitely, this affects a lot, okay? So the contextual information that we find, I mean, obviously, for instance, a pharmacy in a central city in rural areas changed completely. Also changed for the profiles of the patient or the frontline health workers, but this changed dramatically. We also work with health navigators that try to find out, trying to facilitate to users in some countries in Africa to just navigate into the healthcare system. That is extremely complicated. And also we find differences there are differences between the clinics and even doctors, okay? So, and yes, I mean, we try to provide this information to address the patient that try to go to one place or another. But yes, a lot of that. Thank you.
Hi, this is a quick question about how you're doing things at your organization. One thing I know I've really experienced at work with COVID is just like really struggling to get to.
Can you get a bit? Yeah, thank you.
One thing that's been really hard with COVID is getting to know the people that I work with, and I'm curious to hear from you, running a very international team, like what are some of the things that you found worked for you in terms of helping your team build connection with each other?
You mean, management in the team, or?
I was thinking primarily, yeah, within your team, like the employees getting to know each other, and maybe to some extent also your employees getting to know the folks that they're also serving. So,
okay, to make something useful is that part of the leadership team, okay, we're working together for many years, okay, so we are a startup, but at least this was helpful. We have a hybrid system, okay, so we have people on site, both in Lagos and in Barcelona. This helps, okay, with a startup starting from zero, okay, being sitting together even in pandemic, we were with masks, with codes, windows open, we were hard, it was very helpful, okay? So, and also, I mean, it was challenging because at the end, it's people coming from all around the world, and communication is challenging. Communication between engineers and data scientists, I think, is even more. So, I think, yeah, communication is one of the most important parts. But basically, working chair with chair, it has been helpful.
Thank you.
Thank you.
Great work. Question, I didn't know whether or not in your work you encountered on part of the patients, suspicions and mistrust of the platform or recommendations, and if there are any things that you are thinking about or had to do to kind of relieve some of that. I mean, personally, I was surprised. In my home country, there's a lot of suspicion about COVID vaccines and, conspiracy theories and all kinds of stuff that you're like, what? But people really believe them,
So which country, if I can ask?
Guyana.
So, okay, with our partners, what we find is that they are very busy and sometimes they don't understand the benefits that technology can bring, okay? More than trust or not the type of recommendations, because at the end what we are doing is experimentation, okay? So they are going to see clearly if something is working or is not. In terms of patients, to nudge them for vaccination, for instance, I mean, now that the malaria vaccine is going to be deployed and so on, this is something that we take into account. This is why behavioral scientists exist, okay? So maybe we don't need to convince them to take the vaccine, maybe we need to incentivize. So basically, well, what's happened with COVID, okay, in most of the countries. So intervene, basically. So, but yeah. Let's find out what works and what doesn't.
Let's try. Yeah, thank you.
Thank you.
Since you're essentially building sort of a medical history record of patients, what is the consent model, user consent model, for collecting and building that sort of information? And is that collection only possible because countries in Africa have less strict and less comprehensive medical record privacy laws?
So, well, first, I mean, we are based in Barcelona, so we comply with GDPR, okay? So, second, it is true, in every different country, the norms are completely different. Completely. I mean, some of those, they want us to run in their servers in their country, which, I mean, we are not sure because of security reasons. What we do at the end, and we have a very strong partnerships team, is to make agreements with the government. So for instance, in Kenya, we are working to make a dump of our results every day and put it in their servers, and this is enough. So we need to invest a lot in research about the law and partnerships with key people. Our partners are very helpful, but at the end, I mean, all the data is anonymized, obviously, because we cannot have it again, I mean, because we comply with the GDPR. But we not only comply with GDPR, we comply with many different things in every country that we deploy.
So the development world has a bit of a history around looking at single effects as like a magic bullet, specifically Dr. Kramer, whose Nobel Prize work that you mentioned, his original study on dewormers was eventually they went back at looked at the data and disproved that, but at that point those values had already been extracted to almost like, I think 140 million kids in India. So how do you kind of avoid one over extrapolating across different geographic areas? And also in the original study that they found that some of the effects with the dewormers had more to do with how people were interacting, or how the people conducting the study were interacting with the students in the schools to improve attendance, as opposed to just looking at the actual like medical distribution of like the deworming tablets. So how are you differentiating those kinds of different factors in the ways that you're applying the data?
Okay. So something important is that at the end, I mean, the work that I mean this team, I mean, was doing is slower. Okay, so it takes years to at the end analyze the data, see the conclusions. I mean, the cycles of deploys are extremely slow. Okay, so I mean, we believe that I mean, when we scale at that size, okay, so we are able to see changes very fast. That's the power of digital data, of working with mobile apps. So of course, I mean, if we have something that works extremely well for all population, that we go to the personalized level again. Okay, so that's something that also differentiates. That's something that we can do thanks to the technology. But if we see something that works very well in Kenya, we want to deploy in Uganda. Okay, the a priori information, the a priori intervention that we can do in experiment, it can be the same, and see how people react and who react to this. But definitely we are not going to assume anything. And this, I mean, this type of technology allows us to see faster and react faster.
Thank you.
Thank you.
So my question is this. First, thank you so much for what you guys are doing. And so like developing countries like Nigeria, for example, there's a lot of corruption. And how are you handling this corruption to be able to get the result you want?
That's precisely, for instance, in the type of B2B e-commerce apps. That's part of what we are trying to to avoid. Okay, so directly the fact that the pharmacies are able to buy to the distributors, we avoid many layers, okay, of also corruption. Okay, so that's one of the things. Also with the data, we will be able to see all related with drugs that they can, pharmacies indeed sell, that they are, I mean, drugs that they are not official drugs, or coming from other countries that they don't have the stamp. So all this type of corruption also that happens in the pharmacy, we'll be able to see. Okay. Obviously, we would prefer that countries' government change from the root, okay? But in the meantime, this happens. Let's try to have better accountability, and let's create systems that avoid or at least reduce the way that I mean, corruption is established. But yes, we are aware of yeah.
Thank you.
Thank you.
Okay, I think that's all we have time for. Thank you so much, África.
Thank you.